Yes, good evening, everybody. And my presentation is on rectal cancer staging. I will be talking a lot about actually MRI. So it's rectal cancer MRI staging and restaging. So colorectal cancer is the second most common cancer in women and third in men. It is the third leading cause of cancer deaths in United States. Although lower prevalence in India, but it is the seventh leading cause of cancer deaths there. About 27,000 new cases of colorectal cancers were registered in India in 2018, and about with 20,000 deaths that year. One third of the colorectal cancers they occur in the rectum. I will straight away go to the AJCC TNM staging. So when we do the TNM staging just for any other organ, T staging, tumor assessment, nodal staging, N staging, and M staging. For rectal cancer, the T staging from the management point of view and also from the imaging point of view, the important thing is whether the rectal tumor has infiltrated beyond the muscularis or beyond the rectal wall. If it is infiltrated beyond the rectal wall, it is a T3 rectal tumor. Otherwise, if it's confined, it may be T2, T1, or below. If it involves the adjacent organs, is T4 or peritoneal reflection, T4. Based on lymph node involvement, we have N positive, lymph node positive disease or tumor deposit positive disease. M staging based on the distant mets. So lately, or in, like till maybe last couple years, NCCN guidelines were for the management of rectal cancers were all based on the TNM staging system. On imaging, if we see all these masses, as we see here, rectal mass confined to the rectal wall, muscularis is slightly attenuated overlying the rectal, overlying this mass here, suggesting muscularis is infiltrated. So it's a T2 rectal tumor. But when there is a distinction between like T1 and T2 needed, MRI is not good for that. When the rectal tumor has infiltrated beyond the muscularis propria, as we see here, if it is less than 5 millimeter infiltration, we call it as early T3 rectal tumor, or it can be T3AB. A is less than 1 millimeter, which is sometimes hard to say on imaging. B is less than 5 millimeter infiltration beyond the muscularis. If the rectal tumor has infiltrated beyond the muscularis more than 5 millimeter, then we call them as advanced T3. More specifically, if you want to call them, T3C is like 5 to 10 millimeter infiltration. T3D when it's more than 10 millimeter infiltration beyond the rectal wall muscularis. If they involve the adjacent organs, like here the cervix and is involved, the bladder is involved in this case, it's a T4B rectal tumor. And if we see the lymph nodes clearly abnormal, then we call them as node positive disease on imaging. If the peritoneal reflection is involved, we call them as T4A rectal tumors. So TNM staging basically takes care of these prognostic factors of depth of tumor infiltration, as in T staging, lymph node involvement, and metastatic disease status. But there are additional risk factors like the location of the rectal tumor. Rectal tumors, we classify them based on the location as lower, mid, or upper rectal tumors based on the distance from the anal verge. The lower rectal tumors are basically 0 to 5 centimeter, mid 5 to 10, and upper 10 to 15 centimeter from the anal verge. And the location of the rectal tumor can be prognostic as well as it can change management. Other than that, circumferential resection margin, also called as mesorectal fascia involvement, can also change management. It can be prognostic. It can assess. It can prognostic predict the recurrence after surgery. Extramural venous invasion can predict the distant mets. How they affect. So lately, there has been significant progress in the management of rectal cancers. Several advanced surgical techniques, adjuvant therapies have come, which have improved the outcomes in these patients. Advances in the surgical technique can be based on the location of the tumor, depth of infiltration. Like for example, if it's a T1 rectal tumor, it can be handled only with submucosal resection using endoscopy. No other treatment needed. But if it is other than that, T2 or early T3, less than T3 rectal tumors without any risk factors, they can go to upfront surgery. And the surgery can be different for different patients. For upper and mid rectal tumors, we can just do lower anterior rectal resection and block resection of the rectum, and you see this black line here suggesting mesorectum. So if you resect only this part, low anterior rectal resection for the mid and upper rectal tumors. But if the internal sphincter is involved, patient is young, sphincter preservation is needed, then you can extend the same plane in the intersphincteric plane, calling basically anterior rectal resection with intersphincteric resection. If it's a low rectal tumor, anal canal tumor involving sphincters, then we need abdominoperineal resection, as shown by this dotted line. But if the levator is involved, then we need to do extra levator surgery. So based on the tumor infiltration depth from the rectal wall, involvement of the sphincters, upper, lower rectal tumor, surgical technique can vary. Going beyond, if we have more risk factors like nodes are positive, patient has EMVI, or patient has CRM, circumferential resection margin involvement, then this patient basically needs some kind of upfront radiation or chemotherapy, chemoradiation therapy, so that we can debulk the tumor, downstage it, and do future surgery. When we do radiation, usually pre-surgical radiation is preferred over post-op, because if we give post-op, then there will be post-surgical complications, leak, fistulas, all those things. Regarding the T staging and pre-op, regarding the T staging and neoadjuvant therapy, if the patient has T1 and T2 rectal tumors, we do not want to give them radiation, because it will lead to unnecessarily significant morbidity in this patients related to sphincter dysfunction and other things. But at the same time, if the patient has advanced T3 tumor or other risk factors are there, we want to give them chemoradiation. Why? Because if we don't give them, then these patients will have high local recurrence, up to about 27%, poor survival, as much as 48% 5-year survival. So when it is deserving, we want to give chemoradiation, but when it's not necessary, we do not want to give, to avoid over or under treatment. So there comes the value of MRI on the table. There have been several studies, including the Mercury trial, which says that high resolution MRI, it's not some conventional regular pelvic MRI. It has to be high resolution MRI. It accurately predicts the involvement of surgical resection margin, also called as CRM or mesorectal fascia. It can evaluate extramural venous invasion. MRI is reproducible. It allows triaging for treatment. It improves the specificity for nodal involvement. Basically, what we need is high resolution MRI, T2 weighted imaging using phase direct coil for optimal morphologic local staging. If we want to evaluate distant mets, when we do CT scan, if T1, T2 differentiation is needed, then MRI is not good. We do endoscopic ultrasound for that. But for the most part, for local staging, otherwise MRI is the way to go. It improves the selection of therapy, indication of therapy in these patients. So all these prognostic risk factors, earlier we were going by TNM staging based model based management. Now we have switched to MRI based risk stratification, leading to management guidance. So again, because of all these factors, preoperative staging of rectal cancer with high resolution MRI is now widespread. It will help triage patients to upfront surgery, type of surgery as we saw here, the type of upfront therapy too. Overall, high resolution MRI is the key for treatment decisions and surgical planning. But there are some caveats. Contrary to common belief, there can be significant inter-observer variation in these patients, even in the high volume centers, and that can lead to over-treatment or under-treatment. So we have to be careful about that. As in our center, I did this study and of several cases, and we saw there can be inter-observer variation, maybe between 55 to even up to 100%, depending on what factor we are evaluating for these patients. So we want to do good MRI, good interpretation, because MRI is the key for accurate management of this case. So the first foremost is multidisciplinary management. Multidisciplinary team means your team with radiologists, surgeons, oncologists, radiation therapists, pathologists. Usually, the findings of high resolution MRI should be discussed within the multidisciplinary team, and the therapeutic strategy should be managed. Regarding the rectal MRI, there are two key steps, two fundamental pillars. We want to do it with a proper technique so that we get a good image quality. And then once we get a good image quality MRI, high resolution MRI, then we want to interpret it correctly. For that, we may need to train our radiologists, and it may need some learning curve. So to do rectal MRI, first the prep. Whenever we are planning rectal MRI, we want to review the prior images, history of the patient, check for prior therapy, location of the tumor. We can see the endoscopic findings, endoscopic results, what is the size of the tumor, and always request the patient empty the bladder and rectum before getting on the table. If we know from the endoscopic findings, reports, other history that if the patient has small tumors, villous tumors, prior therapy is done, then we can administer 60 to 120 ml of warm gel in the rectum and do the scanning. Remember, do not over distend the rectum, because if it's a lower rectal tumor, it can um, lead to misinterpretation on the rectal MRI. Also, if we overdistend, it can also lead to peristalsis in the patient and unnecessary motion artifacts. So be careful. And we always position the 8-channel cardiac coil appropriately. If it's a lower rectal tumor, we want to shift the coil a little bit inferiorly as compared to the coil for the mid and upper rectal tumors. So again, for rectal MRI technique, key is high resolution T2 weighted imaging in 3 planes. Here, as we see here, phased array coil is placed on the patient. We sometimes can perform 3D weighted 3D T2 weighted imaging. We do this sometimes if we are planning some fusion for surgery, or our if the SNR is not good on 2D images. I'll show you an example. Diffusion weighted imaging for all the rectal MRs we do now. If the patient had some type of therapy before resection or adjuvant therapy, etc., then we give IV contrast. Rarely for lymph node, if the lymph node assessment is the key, then we can give iron oxide contrast, but that's very rare. How to do rectal MRI? First, we obtain the localizer sequence. Then, based on this localizer sequence, we see the rectal axis and anal canal axis, and then we plan the sagittal images, as we see here. After we obtain the sagittal images, see the rectal tumor. We want exactly perpendicular to that axis of the rectum where the tumor is, and that way we obtain the axial oblique images, as we see here. And based on this sagittal images only, we plan the straight coronal. Remember, straight coronal, it's not parallel to the rectal axis, it is straight coronal. So how to once we obtain this rectal MRI, we want to see the ideally we should be able to see all these rectal layers, mucosa, submucosa, muscularis. We obtain thin slice imaging, 3 to 4 millimeter, in plane resolution of 0.5 to 0.8 millimeter. Field of view is small, 14 to 18 centimeter, but if you are struggling, we usually do 18 centimeter because of the SNR issue. 256 matrix will be good also for scanning. Again, the image should be free of motion artifacts, so then we can interpret it accurately. I'll show you a few examples where we went bad. Like here in this patient, we have this rectal mass, and first the technologist scanned. The axial image was scanned just like a conventional pelvic MRI, but when the image came out, you see there is a blurring of this muscle. I mean, we cannot even see muscularis here. Blurring of the rectal tumor margin, looks like it's a T3 tumor. But when we repeated the same sequence, now here there's a sagittal here in the window down, and then you can see we repeated with the plane perpendicular to the rectal axis where the tumor is, and we can see the muscularis is totally intact. So it is basically a T2 rectal tumor. Based on this image, it looks like T3, but if you scan it properly, it's actually T2. Okay, why do we do straight coronal? Because it is not much affected by motion images. Coronal image will give us one more plane for consistent assessment, right? Many of the surgeons prefer this coronal, straight coronal, because they can see the rectal tumor very well, and also you can assess this sphincter involvement, levator ani involvement, pelvic side wall involvement very well on the coronal images. Some people even prefer to do the to see the nodes also on the coronal images. So motion artifacts can significantly compromise image quality, as we have seen, and it is most commonly on the sagittal and axial images. So we want to mitigate that. Most of the motion comes from either anteabdominal wall, sometimes bowel or bladder. If it's a bowel motion, you can try glucagon, hyoscyamin. We have started giving hyoscyamin in our patients, and glucagon case by case. Anteabdominal wall motion, we have to do it on the table. For the bladder, we tell the patient empty the bladder, but if there are pulsation artifacts from bladder, then we try to switch the swap and frequency and then adjust the next and FOV. Here example, we have a patient with a high rectal tumor. Hard to see on this first sagittal sequence because of this ghost artifacts, motion artifacts from the abdominal wall. But after we put the white saturation band on the anterior abdominal wall, there are no motion, there are no artifacts, and we can see this rectal tumor very well. Another patient, utility of 3D. Sometimes on the 2D images, we may have poor SNR, as in this patient. The submucosa is blurred, muscularis is a little bit blurred and looks irregular, causing some confusion. But when we do 3D, 3D imaging is basically volumetric imaging, right? So you're trying to have better SNR. And in this patient, we can see the rectal tumor is, it's basically T1 tumor only in the submucosa, not even going to the muscularis. On this 3D image, we could see it better. Regarding the utility of rectal gel, as we see here in another patient with upper rectal tumor, now I know in retrospect there is a rectal tumor, but when in the beginning, when we did and we were scrolling through different images, hard to see. But from the endoscopy also, we knew that it's a small tumor. We administered rectal gel in this patient. Rectum is distended. We can see this rectal wall, rectal tumor very nicely, and then we can see the rectal tumor here also very nicely. Again, as I mentioned, we administer only 60 to 100 ml. Do not over distend, because you do not want to efface the perirectal fat if it's a lower rectal tumor, and it can cause unnecessary peristalsis also. Okay, once we acquire the MRI with a proper technique, then we need proper interpretation. So we have to read the rectal MRI very carefully, especially when there are motion artifacts. The first thing, always define the site of tumor contact. What is the origin? Which rectal wall? Anterior, posterior, lateral wall? And then try to assess two planes, at least two planes. Multiplanar assessment is the key, so that we can achieve improve consistency and reduce the inter-observer variability in assessing these patients. For example, we have this rectal mass here. We can see actually there is a bump along the left lateral rectal wall. It was tempting us to say that, oh, it's probably T3 rectal tumor. We Unfortunately, rectal gel was not administered in this patient, but on the same day CT, we had CT was done for staging purposes. We can see the rectal tumor is actually along the anterolateral wall, not along the lateral wall. So this bump was actually a fake. It was actually a T2 rectal tumor. Okay, how to assess the infiltration beyond, in the mesorectal fat beyond the muscularis? So first, again, localize the attachment of tumor. Then you draw the imaginary line along that muscularis propria, and after you draw the imaginary line, then you assess how far the tumor has infiltrated, and that way you will get a consistent T3 early or T3 staging of the tumor. Sometimes even after doing that, there can be mistake, because you have to remember there is also a muscularis mucosa. There is another thin muscularis layer in the mucosa. Don't mistake that with the muscularis propria. Muscularis propria is the outer muscularis layer. So if you assess from here, it looks like advanced T3, but if you properly assess from the true muscularis propria, then it's actually a early T3 rectal tumor. Multiplanar assessment is key. Again, here is another rectal tumor on the coronal images. It looks like some irregularity along the rectal wall, but when you see on sagittal, the rectal wall is clear. There are only some vessels going there. So it was basically T2 rectal tumor. So multiplanar assessment is key to accurately do the T staging. Assessment of desmoplasia, we see desmoplasia sometimes in these patients, so you have to be careful. If it's a thin and smooth fine lines, these are just vessels, hyperemia related to the tumor, as in this polypoid mass which was T2. But if you really see nodularity or broad-based intermediate signal at the base of this spicule, then that is actually a true desmoplasia, true spiculations, and that defines the T3 rectal tumor. After doing T staging, nodal involvement. Again, assess the image quality first. If there are motion artifacts, be careful. Then second step, once you see the lymph node, see in two planes. Again, assess in two planes. Assess the texture, homogeneous or heterogeneous, smooth marginated or spiculated, whether it is a fat or no fat. If you see at least two of these factors, at least in two planes, then you call that as abnormal node. If the node is more than 9 millimeter in short axis, there is a very high chance that it's going to be malignant. So more than 9 millimeter short axis node, we just call them as abnormal. But if it is less than 8 millimeter, or and then if we don't see a clear any of the abnormality like texture or margin related abnormality, then those are normal. If it is greater than 8 millimeter, but if everything is good, smooth margin, homogeneous, fat signal is proper, then it's an indeterminate node. So here again, there is a node in this patient with rectal tumor. The tumor was along the left wall, and this node looks irregular on one plane, but on the another plane, it looks very smooth marginated. So it was actually a benign node. If you see only on one node, there may be slight motion, which is causing some irregularity of this node. Another patient, rectal cancer here, looks like T3. So even the pre-test probability is high because it's T3, right? And anyway, and the axial and coronal, both the planes, it looks slightly irregular. The fat signal is gone, so it's an abnormal node. So assess in at least in two planes, two perpendicular planes will be good. And here there are numerous nodes, so clearly abnormal. Pelvic sidewall node is also abnormal. The fat signal is gone, so nodal involvement. Extramural venous invasion, again, define the site of primary tumor, and then we see the vessel follow the if it goes along the course of the vessel and the vessel is expanded, we call it as extramural venous invasion. Sometimes despite that there may be mistake, as in this patient there were few nodes arranged in chain, lobulated nodes, so somebody called it as venous invasion, somebody called it as nodal disease. But for most part we can perform very well if we do multiplanar assessment, avoid the motion artifacts, do proper technique, assess on a good image quality MRI. Sometimes there are fundamental problems related to the staging criteria or the risk factor criteria. Here, this patient has EMVI also and extramural infiltration at the same place. So somebody may somebody may say, oh, the infiltration is all the way up here. Somebody may say infiltration is here. So we need to address some of those TNM staging risk factors. Sometimes there can be one interpretation error or variation just because this tumor is now abutting the seminal vesicle. Somebody may say it's just advanced T3, it has not infiltrated seminal vesicle, but somebody may say, oh, it's the seminal vesicle is involved, so they may say T4B. So we need to work on nitty-gritty of some fine details, but overall MRI has a very good performance so far, and it can do much better if we have a good image quality and do multiplanar assessment. Switching gears, pelvic sidewall lymphadenopathy assessment is very important. Why? Because it is associated with a high risk for pelvic sidewall recurrence. So if we see pelvic sidewall nodes, our surgeons now, after they, of course, downstage the patient, they go and do the lateral node dissection. Or if it is not feasible because of risk factors, etc., or the node became indeterminate, then they also do intraoperative radiation. Basically, the abnormal nodes are the ones which are more than 7 millimeter in short axis, internal iliac and obturator node chain. But before calling pelvic sidewall lymphadenopathy, always remember pelvic sidewall lymphadenopathy. Go for the pre-test probability. If it's T1, T2, it's very unlikely that that node is abnormal. So the tumor should be T3 or T4. They should be low and mid rectal tumors up to about 8 centimeter from anal verge. Why? Because pelvic sidewall nodal mets are rare if it's a higher rectal tumor. So we are the radiologist. Remember, the radiologist is also a consultant for the clinicians, oncologists, and surgeons. So we also have to do a clinical approach, not only just reading approach. And then always remember, if we see external iliac lymphadenopathy or inguinal lymphadenopathy, those are actually M1 metastatic disease, unless the tumor has crossed below the dentate line. Restaging MRI. I will show a few slides about restaging MRI. Restaging MRI is very helpful because once we do neoadjuvant therapy for these patients, the patients are being debulked or are being downstage for future surgical options. We want to see whether whatever therapy we are giving, whether it is making difference, whether the patient is improving, whether the cancer is worsening, there is a regrowth of tumor, or the patient is developing new mets. And the patients who have been treated, who undergo because of that they have achieved partial response or complete response, they may want to even avoid surgery, and they may go for watch and wait approach, even especially if they have no residual tumor. And restaging MRI, of course, can again help for planning the surgical approach. But whenever we are planning surgical approach, always remember baseline MRI is the key. Keep those findings in the mind. Restaging MRI is also useful because it actually gives you tumor regression grade, which is actually a driving factor for survival in these patients. Although for surgical planning, we need baseline MRI. So there has been several tumor regression grading systems proposed. Like for us, the radiology system was actually opposite the pathology system. But whatever we follow, we need to have some consistent method. And now we are getting more and more consensus. And then based on Society of Abdominal Radiology guidelines, we have this MR tumor regression grade system. It is called MRTRG. TRG0, basically, if it's a complete response, if we see a thin pencil line, thin sharp scar and normalization of rectal layers at the site of tumor, no restricted diffusion, we call it as TRG0. But if we see the scar is thick, equivocal, we see some punctate or linear diffusion restriction, we are not sure, we call it as TRG1, near complete response. But if we see clearly there is a residual tumor, although there is some fibrosis also and restricted diffusion, then TRG2. If there is no treatment response, there's like a whole tumor is remaining, minimal fibrosis there, then we call it as TRG3. Here I'll show you a few examples. Here we have a T2 rectal tumor in this patient. The top images, bottom images show after neoadjuvant chemoradiation therapy, it was replaced with a thin linear scar and rectal layers were normalized, no restricted diffusion, so it was a complete response, TRG0. Another patient with a big rectal mass, here on the top images we can see, with restricted diffusion. After neoadjuvant therapy, the tumor shrank down in size significantly, but there was still residual tumor. It's a TRG2 but with partial response. Another patient who had a big rectal mass, mid rectal mass, here we can see in this first column. And then after treatment, you can see this shrank down in size, significant fibrosis. It was partial response, but still TRG2. But after following more, you can see this tumor is showing regrowth, worsening. So now it shifted from TRG2 to TRG3 with restricted diffusion and worsening. Here's another patient with a rectal mass, restricted diffusion. After treatment, very thin linear scar. It was actually a complete response. Somebody may argue, maybe say a near complete response. But the key is wait and watch. When wait and watch, we have to closely monitor. And monitoring after 3 months show the scar is getting thicker. So it's probably patient is worsening here. We did a further follow up. We can see there's clear a worsening of the tumor endoscopically as well as on MRI, clear restricted diffusion. So patient, although received had complete response, it started regrowth, recurrence. So recurrence happen in about 5 to 33% of these cases, mostly within the 2 years. And so monitoring is the key. Although even if they recur, salvage therapy can be done. Surgery is still possible, especially if we detect them early. If we detect them late, then they may become non-surgical candidates. So especially we do monitoring here every 3 months and alternate with endoscopy also every 3 or 6 months, so that we have a control over these cases. Regarding the pelvic side wall lymphadenopathy, uh, neoadjuvant chemotherapy can help to downstage them. Here, as we see, the big obturator node shrank down in size. And when the surgeon is planning the surgery, on the post-treatment MRI, they see the internal iliac obturator nodes, whichever were abnormal. If the internal iliac node is more than 4 millimeter size or the obturator node more than 6 millimeter size, then they plan the lateral pelvic node dissection, or they may do intraop radiation therapy for these nodes. So in summary, high resolution T2 weighted images in 3 planes using thin slices is the key for optimal morphologic analysis and accurate T staging of the rectal tumor. We use body coil, use small FOV, achieve good SNR with T2, 2D T2 weighted images. If not, use 3D T2 weighted images. We can administer rectal gel or contrast, especially if the tumors are small, if the patient had prior therapy. Achieve good rectal MRI with good quality. Interpret carefully, especially when there are motion artifacts. Always when we are analyzing the rectal mass, first thing, define the site of tumor contact, and then say whether there is tumor has infiltrated beyond, as I showed you an example. Then say whether there is EMVI. Always do assessment on 2 planes, at least 2 planes. Multiple assessment is key to even say whether it is T3 or not, even whether the node is abnormal or not. Multiplanar assessment is the key. And be aware of the changing management paradigm. Earlier, we were using TNM based NCCN guidelines. Now we have shifted to MRI based risk stratification models for triaging these patients and helping management. So thank you so much, Onco Imaging Masterclass Online, Dr. Swami, for inviting me here for this lecture. And here my acknowledgement. Thank you to the MD Anderson Rectal Group. Here is my team, who with whom I work day to day on these patients for helping surgeons and oncologists guiding management on these patients. Thank you.